All right, Dr. Winkler, I'm Dr. Shavinsky. Good afternoon. We're going to be doing a mock oral exam. We're going to present several cases. We'll then go over your results and then have some teaching points about the case. All right?
Great, sounds good. Thank you.
All right. So your first patient, a 40-year-old woman, she is 7 months pregnant. She's found to have a mass in her right breast and she's asymptomatic. She found the mass during a self-exam 1 month ago, and she feels that it's getting bigger and more firm than the rest of her enlarging breast. She is in your office for an evaluation.
Okay, I would begin with history and physical exam, going over the Gale model questions with the patient, and an exam of her bilateral breast and axilla.
Okay, so she had menarche at age 12. Her last period was 7 months ago. She is gravida 0, gravida 1, para 0, currently pregnant. She used oral contraceptives for 10 years. She has no family history of cancer. And when you examine her, you feel a mass in the upper outer right breast at 3 to 4 centimeters in size. It is well circumscribed. It is not fixed to the skin of the chest wall, and it's movable.
Okay, so at this point, I would proceed with labs and imaging. I would just get a basic set of labs on this patient, as well as a bilateral diagnostic breast radiograph.
And what type of radiograph are you going to get?
A diagnostic mammogram.
Okay. You realize she's pregnant, right?
Yeah, I realize she's pregnant. I think I agree that ultrasound would be an alternative in this case, or MRI for that matter. But I think it's okay to have a mammogram.
Okay. So mammogram and ultrasound are done. This is the ultrasound image. Demonstrates a roughly 3 centimeter mass in the upper outer breast, and it is palpable. And it correlates with the mammogram as well.
And at this point, I would also try to obtain an image-guided biopsy of this mass.
Okay. And what type of biopsy would you do?
A ultrasound-guided core needle, ideally.
Is this something you're going to do yourself?
I would refer it to interventional radiology for that.
Okay.
You're on George Clay.
And the biopsy comes back as most consistent with a lactating adenoma.
Lactating adenoma. Okay. In that case, then, since this is a benign lesion, I would counsel the patient to wait until her pregnancy is completed, and kind of monitor her during the breastfeeding period if she does plan on doing that, to see if this mass is symptomatic or changing at all.
Well, she'd like to breastfeed. Would that change your plan?
No, I think it's okay for her to continue breastfeeding through this, as long as the symptoms aren't prohibitive.
How long would you let this mass persist?
I think if she's planning, I guess I would try to gauge how long she's planning on breastfeeding for. But I think it's okay to serially observe it in 6 months. Also, she seems to have a pretty good handle on its size. So if it's increasing and bothering her, then I think we could change our plans.
So your next patient's a 42-year-old woman. She comes to your office after an incidental finding on a routine mammogram. This showed some calcification, and a stereotactic core needle biopsy revealed a pathologic diagnosis of usual ductal hyperplasia with LCIS. She performs monthly self-exam and has never noted any abnormalities. She's otherwise healthy and in good, and her physical exam is normal.
So at this point, I would just get a little more history from this patient, make sure that she's been having regular screening mammograms, I guess, since age 40. I would explain that LCIS is essentially a risk factor for breast cancer, but not in and of itself a concerning finding on the lesion itself. Otherwise healthy.
All right. So
I think the other things to discuss with her are just the possibility of chemoprophylaxis, but I would want to know about her plans for childbearing and when the Gale model question. I would assess her other risk factors for potential breast cancer.
okay, what are the risk factors you would assess?
I would go over the Gale model questions with this patient as well. Family history, any prior breast biopsies, age of kind of her duration of exposure to estrogen.
Okay, so she had menarche at age 12. Her last period was 2 weeks prior. She's gravida 3, para 2 with her first child at age 27. She used oral contraceptives for 10 years. She doesn't currently. Her aunt, her mother's sister, had breast cancer at the age of 60. She has no breast symptoms. She's had 2 C-sections, and she's on Synthroid for hypothyroidism.
Mm-hmm. Yeah, none of those were really red flags for me in terms of her risk being above the kind of baseline risk of the population. So I would counsel her that she could stay on her usual routine screening pathway, and we could consider chemoprophylaxis for her.
Okay. Anything else you would do surgically?
No, I think the usual ductal hyperplasia is, I'm not interpreting that as, I think if it were concerning, they would read it as atypical ductal hyperplasia, and that would require a different management. But I think for this, I would just keep her on routine screening.
Okay. So your next patient is a 25-year-old woman who presents to her physician with complaints of a mass in her left breast. She says she doesn't usually examine her breasts, but while taking a shower, she felt a hard mass in the breast. She denies any trauma, pain, weight loss, or fever.
Okay. So I would begin with history and physical exam, like every other patient. I would ask her the Gale model questions, try to figure out her baseline risk, and I would physically examine bilateral breasts and axilla.
Okay, so she is 25 years old. Menarche was at age 12. Her last period was 2 weeks ago. She's gravida 0, para 0. She's been on oral contraceptives for 10 years. Her aunt had breast cancer at the age of 60. When you examine her, you feel a mass, a movable mass in the upper outer right breast. It measures about 2 centimeters. It's not fixed. There's no axillary adenopathy. She's had a history of an appendectomy. She's on no medicines other than the oral contraceptives.
So I would explain to her based on the characteristics that you described that this is very unlikely to be a malignant lesion. But I do think that it's worth it to pursue a bit further workup. I would get a basic set of baseline labs as well as a bilateral diagnostic breast ultrasound because of her young age.
Well, she goes to the breast center and they do both a mammogram and an ultrasound. And that reveals about a 2.5 centimeter ovoid mass with distinct margin. It's in the upper outer quadrant of the left breast.
Mm-hmm.
I'm sorry, upper outer quadrant of the left breast. That's correct.
Mm-hmm. And did they put a BI-RADS category on this lesion?
They called it a BI-RAD 4.
BI-RADS 4. Okay. In that case, then I would proceed to pursue a image guided corneal biopsy.
By the way, what does BI-RAD 4 mean to you?
BI-RADS 4 to me means a moderate risk of malignancy. I believe that's on the order of 15 to 20%.
Okay. If they called it a BI-RAD 3, would that change your approach?
Oh, you know what? I'm sorry. I think forgetting the numbers a little bit. 15 to 20% maybe BI-RADS 3, and 4 is a bit higher than that. 3, I would still perform a biopsy. 2 is definitively benign.
Okay. Okay, so what type of biopsy would you do?
For this, I would do an ultrasound-guided core needle biopsy.
For a palpable mass?
Oh, if it's palpable and it seems reasonably close to the surface, you could do it without ultrasound guidance.
Okay. What would you do though?
If it's palpable, I would do it without ultrasound guidance in the office.
Okay. And the pathology comes back as a cellular fibroadenoma.
Cellular fibroadenoma. Okay. I would explain to the patient that this is a benign lesion. I would try to ascertain if she has any significant symptoms from this. There can be a spectrum amongst fibroadenomas in terms of their risk of growing or being concerning for a type of sarcoma. But I would explain to her that she has the option to have it removed or to leave it in, basically. I don't think it's concerning and it could be reasonably surveilled.
What would your recommendation be?
My recommendation would be it's 2 centimeters, you said?
Correct, 2.5 centimeters.
I would have it removed. I think there's a reasonable chance that this will grow in size and come to cause her symptoms, or the very small chance that it sort of converts to something more concerning. I think it's reasonable to have it removed, given that the morbidity of the potential surgery is small.
Okay. Okay, so you remove it and the final pathology comes back as a benign phyllodes tumor with the tumor at the inferior margin.
Positive inferior margin. Okay. The fact that it's benign phyllodes tumor is encouraging. I think even with a positive margin, the fact that the rest of the tumor was benign, I would counsel her that we do not need to go back to re-resect the inferior margin. I don't think that's necessary, and we would just put her on routine surveillance. I guess it would be starting a bit younger than normal, just for the fact that in case that regrows.
Okay. So you're asked to see an 18-year-old man. He was found to have a right-sided breast mass during his induction physical into the Navy. He said the right breast has been enlarging over the past several months, not painful, and he was wearing loose clothing to cover it up. He denies any medical or surgical problems.
Okay. I would ask the patient a few questions: family history of breast cancer, any exogenous hormone or steroid use, and then I would physically examine bilateral breasts and axilla to see if there was symmetry or a discrete mass as opposed to sort of a swelling of the breast.
Well, he used anabolic steroids for weightlifting and building muscle. He also occasionally uses marijuana. His aunt had breast cancer at the age of 60. He felt this growing over several months. When you examine him, he's got symmetrical and soft enlargement of the breast with no focal masses.
Yeah, so I would explain to him that this is very likely to be a side effect of that steroid, and possibly also the marijuana use, called gynecomastia, and it's just a benign enlargement of the breast due to hormone changes that seem to be self-induced on his part. I would counsel him to discontinue both of those and see if it improves.
He's very embarrassed about the way it looks.
Yeah, I think the same advice would apply. I think once he withdraws the hormone sort of dysregulation, that they should improve.
He's wondering if there's any other options.
I wouldn't start with that. No, I would discontinue